So I'm hoping that we are all going to learn from the session, and we are going to discuss together. So if you will have any questions, we will invite you to come to the chat box and just write either your question. Sorry for that. I just got a small hiccup. But as I was saying, is that we are privileged to have a renowned speaker with us, who is Agri Nyaboga. And to those of us who are still saying no sound, I hope you can hear me now. Yes. So we are privileged to have Agri. And Agri, if you can hear me, you can share your screen, and probably you can start. Agri, can you confirm that you can hear me? Okay, so as I was saying, we are privileged to have Agri Nyaboga, who is a seasoned medical lab scientist, and he holds a BSc in medical lab science, and currently pursuing a master's degree from the University of York, UK. And Agri holds an IBMS portfolio, and he's very passionate about advancing quality and standards in laboratory medicine. And so he brings quite a wealth of knowledge and global insight also in this field. So Agri, once again, you can confirm that you can hear me?
Yes, Fred, I can hear you clearly.
Very good. You can, okay, we are good. We can see the screen also, and you can proceed.
Thanks a lot, Fred. I'm sorry for that technical hitch. I'm very happy and proud to be associated with LMSK, and really appreciate your audience too in today's webinar. You are welcome on board so that we learn together. Today's topic is cardiac markers, and we are going to check the role of cardiac markers in cardiovascular event diagnosis and management. So we are mainly going to look at what the clinical lab is all about, especially in diagnosis and management of cardiac issues. We are going to look at various cardiac markers that are currently available, and the ones that used to be available, and how they are used to diagnose cardiac events, the cardiac issues across board, and how they are used to manage the conditions associated with the cardiac and also vascular events. Now, we're going to look at, as an introduction, we're going to look at the definition of cardiac markers, what cardiac markers are, and how they are associated with the cardiovascular event. Cardiac markers are substances, usually proteins or enzymes released into the bloodstream when the heart muscle is damaged or stressed, primarily used to diagnose conditions like heart attacks, acute coronary syndrome. Acute coronary syndrome is also referred to as heart attack. So acute coronary syndrome is the medical terminology, but the common term is heart attack, and also heart failure. So when heart attacks usually occur, there is a record high troponin levels that are recorded, and also we'll find out that troponin is the gold standard for heart attack diagnosis due to its high specificity alongside other older markers like CKMB and newer ones for heart failure like natriuretic peptides. Monitoring their levels help doctors to quickly assess heart function, risk, and also they are used to guide treatment. We are going to look at key cardiac markers apart from troponin. We are going to look at CKMB, that's creatinine kinase, MB. We're going to look at myoglobin and natriuretic peptides, that's BNP or NT-proBNP. We're also going to look at high sensitivity C-reactive protein and how they are used in diagnosis of cardiac issues. The cardiac troponin, as I've said, that's the gold standard. It's one of the is the most important markers. One of the most important markers for detecting heart muscle injury, ischemia, or infarction. They rise within hours and stay elevated for longer, making them highly valuable for heart attack diagnosis. The creatinine kinase, that's CKMB, creatinine kinase MB, a specific heart muscle enzyme. It rises sooner than troponin, but also returns to normal quicker, making it useful for monitoring early damage or reinfarction. Even if troponin is the gold standard, there are other reasons as to why we can use other cardiac muscles. As we see in CKMB, we realize that in CKMB, it rises sooner, but returns to normal quicker. So that's why it's relevant in other situations, especially in monitoring early damage or early myocardial myocardial reinfarction. Myoglobin is another marker that's an early indicator of muscle damage for the heart or skeletal muscles. So myoglobin is non-specific, but it can also be used in cardiac issues when specific symptoms come into play. It is less specific, as I've said, and rises very quickly after heart attack. So the symptoms are the clinical symptoms are the ones to make the doctors decide whether they are going to use myoglobin levels in diagnosis of myocardial infarction. There's another cardiac marker that's called natriuretic peptide. Specifically here, we're going to use NT-proBNP. It's usually known as BNP or NT-proBNP. It's used for diagnosis of and management of heart failure as they indicate stress on the heart muscle. This one is commonly used, especially in monitoring treatment. High sensitivity C-reactive protein is also very important, HSCRP. It indicates inflammation and also risk factor for cardiovascular disease. So this is a commonly available test and it's very important. especially when we are making diagnosis or checking the early causes of cardiovascular events. Commonly, in this case, it's usually involved in detection of inflammation, and inflammation is considerably early, an earlier cause, especially the inflammation of the cardiac muscles is a very early cause of, it's a very early lead to indicate cardiovascular events or cardiovascular disease. The clinical significance of cardiac markers. Cardiac markers are used to diagnose, confirming heart attack or MI, or differentiating it from other causes, especially the chest pain. So it's used, they are used in differential diagnosis, either to confirm or differentiating it from other causes of chest pain. Cardiac markers are used for risk assessment, as identifying patients at high risk for complications such as acute coronary syndrome. Prognosis and management, tracking heart failure severity or monitoring treatment effectiveness. So we are going to begin with the details about cardiac troponin. These are markers of myocardial necrosis and ischemia. The troponins are regulatory proteins that are found in skeletal and cardiac muscles. 3 subunits have been identified. We have troponin 1, we have troponin T, and also we have troponin C. Cardiac troponin, troponin I, sorry, not troponin 1, troponin I, CTNI, and T are components of contractile apparatus of myocardial cells and are expressed almost exclusively in the heart. So cardiac troponin I and also cardiac troponin T are key elements in diagnosis of cardiovascular events. Because we find that these are proteins that are contractile, that make the contractile apparatus of myocardial cells. So if they are found in myocardial cells and they help in contraction and relaxation of cardiac muscles, they are almost exclusively in diagnosis of myocardial infarction or very similar issues pertaining to the cardiac issues. 2 different reference ranges are used in troponin assays. We have upper percentile reference range, which gives the upper limit of what can be expected in a normal healthy adult population. Whereas the coefficient of variation is a percentage variation in assay results that can be expected when the same sample is repeatedly analyzed. The fourth universal definition of acute myocardial infarction, that's MI, in 2018. We are going to look at this, what it means, the fourth universal definition of acute myocardial infarction that had its inception in the year 2018. Now, in recognition that cardiac troponin measurements may be elevated in disease states not primarily related to myocardial ischemia, a definition of acute MI was developed by American College of Cardiology, European Society of Cardiology, American Hospital Association, and World Health Federation in 2018. First, myocardial injury is defined as elevated cardiac troponin value with at least one value above the 99th percentile upper reference range. Myocardial injury is also considered acute if there is a rise and fall of cardiac troponin values. So when you are doing the making a diagnosis, we should consider these issues. The myocardial injury is considered acute if there is rise and fall of cardiac troponin levels. So meaning that when cardiac troponins are done, it's not cast on stone that they must be done once. This is the reason as to why someone cannot be referred, especially in an outpatient center, to leave a sample for troponin running, and the patient goes home to come back to check the results later. This patient should be in a situation whereby this patient is around the healthcare facility, possibly being planned for admission, or something like that, or being handled in a case as an emergency case. It should not be treated like any other tests. We should take note that timing levels rise within hours, peak, and stay elevated for days, requiring serial measurements to check the dynamic range. So it's key when you've decided that this patient is in acute condition, and this patient, the symptoms are indicating, are tending towards MI, you should consider serial measurements. And this patient should be considered for acute, for emergency admission. I would like to correct something here, especially for doctors who usually order these tests or request these tests, especially in outpatient care, when this patient is not even being considered for admission. It's not in order. You should advise clinicians you should advise clinicians accordingly on how these tests should be handled. First, the patient should be considered for admission first and emergency admission. And this test is done from the onset of these processes of admission, and again repeated under close monitoring. Serial repeated repetitions of these tests should be considered. Fourth, universal definition of MI 2018 clarifies that acute MI requires acute myocardial injury, has elevated troponin within rise and fall, plus clinical evidence of ischemia. We need to also consider symptoms that are presenting themselves. Also consider the results for ECG and ECG changes and Q waves, especially in ECG. Also have to check imaging abnormalities or thrombus. So this is another consideration for echocardiography, and also ECG, which will be done concurrently together with the laboratory tests. And also other imaging tests like the CT scans to check whether there is thrombus formation or other issues concerning thrombotic risks and thrombotic risks evaluation, and CT scans, especially in checking for the formation of thrombi in the microvasculature, especially deep venous thrombosis. We have also issues pertaining to arterial thrombosis. And this has to enable us to differentiate these issues, especially general MI elevated, especially in elevated troponins, from other causes like heart failure or sepsis. When we consider a range of tests, including ECG, imaging abnormalities, especially the CT scans, and checking for other thrombotic risks, will enable us to identify the cause of the heart problems. And a number of them include also the lab tests, including troponin, CKMB, as I've stated before, that's highly sensitive CRP. There are various types of MI. Actually, there are 5 categories. We have type 1 MI, which involves rupture, stroke erosion, thrombus formation. That's for classic heart attack. Type 2 pertains to oxygen supply and demand mismatch, e.g. due to spasms, anemia, and tachycardia. Type 3 involves cardiac death with suspected MI before troponin or ECG confirmed. Type 4 related to percutaneous coronary intervention, PCI, that's PCI or stent. Also thrombosis and stenosis. Type 5 is related to major surgery. So when we talk about MI, it's not only one type of MI that we have. We have 5 types, and they're associated with various issues here. As we've seen that type 1, rupture and erosion and thrombus formation, that's a classic heart attack that's commonly known. When we have oxygen supply and demand mismatch, due to spasms or anemia, we have a tachycardia, which can also lead to MI. This is the second category, which is called type 2. The cardiac death, MI, is also associated with earlier, especially earlier events before MI occurs, because MI can occur, especially because of very like inflammation and other issues with leading to cardiac death. Type 4 is related to percutaneous coronary intervention, PCI, stent, thrombosis, or stenosis. Type 5 is MI. Surgery also can lead to malformation due to major injury to either cardiac muscles or veins or arteries that are closely associated with the cardiac tissue. The following is an algorithm that can be used for differential diagnosis of cardiac associated conditions. When there is an elevated cardiac troponin, as we've seen, greater than 99 percentile upper reference range, upper reference limit, we should check for 2 things. Are troponins either on the rise or fall? There is a trend of either rising or falling of troponin. Also, we check whether the troponins are stable. What happens when troponins are stable? In differential diagnosis, we will infer that due to stable troponin levels, even if they are abnormal, we will infer that there is chronic myocardial injury. And the issues pertaining to chronic myocardial injury are structural heart disease and chronic kidney diseases. There are a wide range of structural heart diseases. Some of them are congenital. Some of them are type 2, that they are caused by secondary causes. So there are a wide range of structural heart problems. Kidney problems associated with the regulation of blood pressure can be associated with a chronic myocardial injury. Now, as a classic symptoms that will enable us to make a clear differential diagnosis whether we have acute myocardial infarction is the rise and fall, especially in our serial testing of troponin. When we notice that there is there are differences, especially in the trend of this troponin as a marker. There we have high levels and low levels, especially in serial testing, will infer two issues. We have MI with acute ischemia or MI without acute ischemia. So we have one denominator across the rise and fall of troponins, elevated troponins over 99 percentile upper reference limits. There is always ischemia. Now, what we need to do is to differentiate between acute ischemia or without acute ischemia. Is there acute ischemia? If we have acute ischemia, then there is acute myocardial infarction. If there is no acute ischemia, there is acute myocardial injury. And in acute myocardial injury, we have examples such as acute heart failure or myocarditis. But when it comes to acute ischemia, we have acute myocardial infarction that can be associated with atherosclerosis, thrombosis, oxygen supply and demand imbalance. And in atherosclerosis, we have plus thrombosis, we have type 1 MI triggers, which can trigger rupture of the vessels and also plaque erosion. Now, type 2 MI examples usually caused by acute hypertension, and also sustained arrhythmia. So these are issues that more often cardiologists use, especially in testing algorithms to differentiate various heart conditions. And with this, you realize that the laboratory plays a key role in diagnosis of this, because this is where we have to monitor troponin levels. We have to check for thrombotic risk testing, and which has a range of tests that are usually done, especially in lifestyle events screening for people, especially who have attained certain age brackets, commonly used by physicians before heart conditions are referred to cardiologists. And they are usually done, these thrombotic risk tests are quite a number. CBC is one of them, liver function is another, LFT is another, blood sugar is another. Also, they also checking also the kidneys, because also kidneys play a great role in checking for chronic myocardial injury. The interpretation move in tandem with the troponins, especially when symptoms have gone considerably far. The next issue we're going to look at is myocardial infarction type 1. We're going to look at the details of myocardial infarction type 1. MI caused by atherothrombotic coronary artery disease. That's coronary artery disease, CAD, usually precipitated by atherosclerotic plaque disruption. rupture or erosion. It's designated as type 1 MI. As I said earlier, the type 1 is usually overt. It's associated with a atherosclerotic plague. And when this plague forms, as you can see in that image, when it forms, it blocks the blood flow. And again, when there is intense pressure on these arteries, they rupture. When they rupture, they lead to cardiovascular events, what we call type 1 myocardial infarction. The tissues die, especially in the occlusion of these blood vessels, leads to thrombosis. Rupturing of these blood vessels will lead to internal bleeding, especially into the heart muscles. This will lead to further occlusion due to formation of microthrombi. You know, in coagulation and hemostasis, there are various issues, there are various factors that come into play when there is a rupture of a blood vessel. The vascular integument of the blood vessels is integrity is tampered with. It leads to a cascade of events that lead to complete occlusion, stop blood flow, and this leads to arresting of blood flow to vital parts of the heart muscles, leading to MI. Myocardial infarction type 2, the physiological mechanism leading to ischemia or ischemic myocardial injury in the context of mismatch between oxygen supply and demand has been classified as type 2. As I stated earlier, when there is this mismatch between oxygen supply and demand, maybe supply of oxygen is less and the demand is more, especially in the heart muscles, can lead to heart failure. What can cause this mismatch? It can be caused by atherosclerotic event. It can be caused by spasms of coronary microvasculature. And these vasospasms can be caused by a number of events. We also have non-atherosclerotic coronary dissection, and this is caused by surgery. Oxygen supply and demand imbalance alone. Oxygen supply and demand imbalance can be caused by, especially when there is exhaustion, maybe due to vigorous exercises. We've experienced people. Okay, if you've not experienced people, be faint after vigorous exercise, especially marathon, even in football fields, people faint and develop heart attack. And this heart attack is usually myocardial infarction type 2. And apart from oxygen and supply demand imbalance alone, we have this atherosclerotic plague, which when they rupture is not termed as myocardial infarction type 2, is usually referred as type 1. But if there is no rupture, it's only to imbalance in oxygen supply and demand is referred. The key patterns and timing. Now, timing levels rise within hours, peak and stay elevated for days, requiring serial measurements to see the onset dynamic change. Remember, we are still on the troponin. We are going to check other elements also, other analytes as biomarkers in the cardiac events. On the onset, troponin levels rise 2 to 3 hours after myocardial injury. So according to the why clinical history is very important, when the clinicians are keen in clinical taking of clinical history, this MI is easily diagnosed. But if one is not keen in asking questions on how the events proceeded, especially in the clinical picture, then there will be no clarity in diagnosis. The peak levels typically peak around 18 to 24 hours after the heart attack. So timing is key. Duration, troponin I, as cardiac troponin I can stay elevated for 7 to 10 days. Troponin T can up to 14 days. High sensitivity, CTN is a newer assay that detects lower levels, allowing for earlier MI identification within 90 minutes and better tracking of small fluctuations. So we also have to consider other highly sensitive cardiac biomarkers, sensitivity, cardiac troponins, for clarity if we are not sure. These are crucial tests that should be made available in many facilities. The second biomarker is creatinine kinase MB, that's CKMB. CKMB is an enzyme primarily found in the heart muscles, historically used as a cardiac marker for heart attacks. MI by detecting its release from damaged heart cells into the bloodstream. But it's less specific than modern cardiac troponins, although it still helps to diagnose reinfarctions when troponins aren't available due to its unique release pattern. It rises 3 to 4 hours, peaks 10 to 24 hours, and remains normal in 3 days. So one has to clearly identify this pattern, and that's why it's very important for the lab to be able to give this kind of information, the trend in which these biomarkers behave. It's good to give the clinicians this information so that it helps them for easier diagnosis or easier consideration of certain interventions. Now, what is CKMB? It's an enzyme of creatinine kinase composed of two subunits. We have M and B, with CKMB containing one of each, making it cardiac specific. So CKMB is useful in specific situations. It's useful in detecting a reinfarction. As I stated earlier, CKMB is very useful for detection of a reinfarction as a second heart attack because its levels rise and fall than troponin if troponin tests aren't available. So you see the relevance of this, especially when troponins are not available. So the release kinetics are as follows. It rises 3 to 4 hours after injury, as stated before. The peak is around 10 to 24 hours, and the normal is within 48 to 72 hours. So as stated, that we should provide key information on the release kinetics so that to prompt clinicians to make quick decisions, especially in emergency interventions. CKMB limitations and comparison to troponin. Intensive exercise or muscular injury can raise CKMB, leading to false positive for heart damage. Cardiac troponins now the preferred marker, because I've stated before that is a gold standard. because it's highly specific to the heart, even in small amounts, offering earlier and more accurate diagnosis or detection of MI. In essence, CKMB helps identify heart muscle damage, but troponin are the gold standard, with CKMB serving as an hinge role for timing reinfarction in source limited setting. So you see the differences between the two and how they should be used. The third marker is myoglobin. Myoglobin acts as an early but non-specific cardiac biomarker, indicating muscle damage of the heart or skeletal. Now, it usually detects heart or skeletal muscles damage quickly, actually within 2 hours after injury, helping to rapidly rule out MI or assess reperfusion, but its lack of specificity means that it must be confirmed with other more specific biomarkers like troponin. So clinical picture also said that one should ask him or herself what preceded to these clinical symptoms, especially for MI. Is it an accident? Is it a strenuous exercise? Is it maybe a perceived MI due to atherosclerotic event or of microthrombi? What is a thrombotic risk? What's the clinical history of previous? What's the picture of the patient? Does the patient have a history? Something that should be considered, especially in such emergency situations, as the emergency is being catered for. There are quick data that should be gathered for clarity. As the tests are running, some consideration have to be considered as other interventions proceed. In essence, myoglobin helps get patients with chest pains to the right place faster, rule out MI, but isn't specific enough to confirm heart attack on its own. So if it's available, it can be quickly be used in tandem with other clinical parameters, the clinical data, to quickly check whether it's an MI or not, or to do a differential diagnosis. Myoglobin limitations as a cardiac marker. It's non-specific as we found that we should be able to check whether we have skeletal muscles involved here. Is there any signal of trauma, strenuous exercise, kidney issues, and other muscle damage, not just heart attack? So other issues should be considered across board. But when these other issues are ruled out, then we can say it's a heart attack or myocardial infarction. If clarity is not sought, we have to seek for to do troponin. Myocardial for myoglobin, it has a short duration because it's cleared rapidly by the kidneys within 24 hours, limiting its usefulness for later diagnosis. Yes, if it's for later diagnosis, then we better consider CKMB or troponin. The current clinical use of myoglobin should not be standalone. Myoglobin is rarely used for definitive MI diagnosis today. It supports troponin. It's used alongside troponins which is the gold standard. And CKMB primarily is for detection of early risk stratification and ruling out MI in emergency room. We are going to look at also the fourth one, which is BNP and NT-proBNP. BNP and NT-proBNP are crucial cardiac markers released by the heart. Now, when are they released? When the heart is under stress, primarily used to diagnose and rule out heart failure in patients with symptoms like shortness of breath, providing excellent prognostic information, monitoring treatment effectiveness, and differentiating cardiac from pulmonary issues with NT-proBNP, often preferred for its stability and sensitivity. NT-proBNP and BNP help to assess risks, guide management, and predict outcomes, acting as a powerful tool for both acute and chronic cardiovascular care. Now, we've seen that among these biomarkers, we have proBNP and BNP as a prognostic marker, provides prognostic information. The key roles of cardiac markers, as we've seen, is to diagnose heart failure. The rule out tests. Low levels strongly suggest heart failure is unlikely, allowing quicker diagnosis and reduced anxiety for patients. Rule in tests. Cardiac markers are used to rule in tests. Elevated levels point towards heart failure, especially when symptoms overlap with lung conditions like COPD, that's chronic obstructive pulmonary disease. Prognosis and risk stratification. The cardiac biomarkers indicate the severity of heart failure and predict adverse outcomes like mortality or hospital readmission. Higher levels signify greater risk in all stages of heart failure, from early changes, stage A, stroke B, and to advanced disease, stage C, stroke D. As you've seen earlier, proBNP and NT-proBNP is an excellent biomarker for prognosis and risk stratification. Cardiac biomarkers are also used in monitoring and treatment. Serial measurements are used to track disease progression in response to therapy. They guide in treatment adjustment and also helping clinicians to understand the patient if a patient is improving or deteriorating. These biomarkers are also used in differentiating causes of dyspnea. Sometimes patients come with dyspnea, and sometimes it becomes difficult to understand what causes this dyspnea. Excellent for distinguishing heart-related shortness of breath from lung-related cases, even with normal echocardiograms. Yes, we know that shortness of breath can be caused by various issues. Others can include even DVT or pulmonary embolism, PE, and Sorry, I'm back again. As can be differentiated, the differentiating causes of dyspnea, they are excellent in distinguishing heart-related shortness of breath from lung-related causes, even with normal echocardiograms. So we should consider such like events that they are available so that we can do a clear differential diagnosis of the same. So the last one we are going to check is the highly sensitive, high sensitivity CRP. High sensitivity CRP acts as a cardiac marker. So usually an important cardiac marker as a measure of inflammation. It usually detects low levels of chronic inflammation, a key underlying factor in plaque buildup, atherosclerosis, that leads to heart attacks and strokes. So HSCRP or high sensitivity CRP, it adds clinical, it usually adds significant predictive value to standard risk scores, like Framingham scores, especially for people with intermediate risks, 10 to 20%, especially like, for example, intermediate risk, 10 to 20%, signifying 10-year risks. So there are various elements, like when we talk about Framingham scores, there are various scores that doctors use to determine the risk of the risks in the risks. Okay, the risk category of patients, depending either on their age bracket or the predisposition of the patient, like the lifestyle issues pertaining to sedentary lifestyle, smoking, and many others, drinking, and many other issues like diabetes that put a patient at risk, especially in developing MI. So the HSCRP is a very important in prediction of MI or heart failure due to inflammation. It's also a prognostic tool because high levels after heart attack or in chronic heart disease predict high risks for future events, while lowering levels with treatment can signal improvement. So it's a very important prognostic marker, just like NT-proBNP or BNP. The clinical significance of HSCRP is that it guides therapy, helps doctors to decide if statins or other interventions are needed, particularly when LDL cholesterol is borderline. Identifies, yes, LDL can be in borderline, and this can confuse the doctors whether to start a treatment or not. But when HSCRP is done, it will give a clear indication. It will now give a clear indication whether the doctor should start the statins treatment or not. It also identifies residual risks, detects inflammation driven risk, residual inflammation risk that lipid-lowering drugs might not fully address alone, pointing to the need of broader anti-inflammatory strategies. Yes, because it's an inflammatory marker, it's used to as an indicator of inflammation to check the risks of inflammation. It's also a very important element, biomarker, that can be done regularly, especially when a patient has come for routine checkup. Patient has come for a routine checkup because this patient is diabetic, or this patient is overweight or obese. This is a very important test that should be considered, especially in regular checkup. So this is the end of my presentation. I'm sorry for a few technical hitches. I really appreciate your audience. I hope you've learned. And this information is very key for us to be able to advise clinicians, especially on specific issues dealing with the heart and tests that come to us. As you've noted, that I usually emphasize in my CMEs that we don't release, we should not only release results and reference ranges only. There is key information that's needed from us, especially to enable doctors certain decisions, because we have this knowledge, we have this information. Why can't we give recommendations on certain issues? That's this CRP, it's this and this level. What is the risk of the patient? What should we consider if this cardiac CKNB is falls within this and this reference range? What about troponins? What should we consider next? Should the patient come directly to the lab and we do the test, the patient goes home without us raising eyebrows on the protocols that should be followed? So it's very key for us to understand information across board so that we are able to advise accordingly, especially when we see, we find out that there are gaps, and gaps can be associated with very many issues across board. You know, issues pertaining to experience also, and also maybe there are so many things that have affect the clinical practice. So we come on board to advise issues pertaining to the tests that we do, the diagnostic information that we release from the lab. That one we should be at par excellence so that we cover most issues that could have arisen from maybe gaps in clinical practice. Thank you. Maybe I will invite Fred. Kindly, you can weigh in so that you can moderate us, Mr. Fred. Thank you. Hello, Fred. If you can hear me, kindly take over.
Thank you, Agri. Are you able to hear me?
Yes, I can hear you.
Yeah, thank you. Fred is not able to speak. I think his microphone is kind of muted, but then I can come in. I can come in and sort the part of Q&A so that we continue. We have a number of questions from our participants, and so we want to answer them. We're looking at them. Trying to check on the questions and see if there are any questions for you this evening, but so far, only comments from the participants. Penina Washira, thanks for your presentation. A number of participants are also inquiring about their CPD points. But I think most of the CPD issues have been sorted in our previous webinars, but we still urge to, so that anyone whose CPD points have not been uploaded, you can as well channel your complaint to the LMSK Secretariat through the numbers that have always been given out, and also the link for complaints, so that your complaints can be sorted. We try to check on the Q&A, but most of the chats you're getting are comments on how they are able to appreciate the presentation that you've given. Yeah, so far we don't have any question from our participants. But yes, one question, we're getting one question from Sir Omar Juma, and the question is, between HSCRP and CRP, which one is considered most when elevated? Agri, are you able to hear that question?
Yes. Now, thank you for that good question, Juma. Now, the key consideration depends on what are we trying to diagnose here. If we are checking for inflammation, general inflammation, especially associated with maybe infection, whether it's a viral infection, bacterial infection, or inflammation caused by other general events like rheumatoid arthritis, maybe issues pertaining to autoimmune conditions, we consider the CRP. However, for high sensitivity CRP, when it's elevated, it's primarily used to check for thrombotic risks, or especially issues associated with heart failure or myocardial infarction. So more often, it can be used to check whether we have a coronary issue here. Is it a coronary? Okay, is it a cardiac issue? Is it an MI? Do we have thrombotic risks? Yes, and it can be used for prognosis, long-term prognosis of the treatment of MI or thrombotic risks, risk associated with thrombosis. It usually moves in tandem with the treatment of atherosclerotic plaques, atherosclerotic events, thrombotic risks, and also MI, and also other cardiac events. So it depends on what we are trying to diagnose. So if we want to diagnose cardiovascular issues, HSCRP is of key consideration. But in general inflammation, CRP is of utmost consideration. Thank you, Juma, for that. And also thank you for others for your responses. Back to you, George.
Yeah, thank you, Agri. Yes, that question has been understood well, and we are getting another question here from Grace Mukua, and the question is, between pro-BNP and troponin, which one is more significant in diagnosing MI? Back to you.
Thank you, Grace. As I stated earlier, natriuretic BNP or brain natriuretic peptide, that's proBNP and BNP and troponin. I stated earlier that troponins are the gold standard of diagnosis of MI, but proBNP and BNP are for prognosis of MI. Prognosis is that we are trying to check the degree at which the treatment is progressing, and if at all we are covering a mileage in treatment, and there is efficacy of treatment of a certain condition, and the outcome of this treatment or intervention, is it good or bad? That's what we call prognosis, and that's where proBNP comes in. But troponin is very key. You remember us talk about greater than 99th percentile score, and here we need to consider rise and fall of troponin, and that algorithm that we use for diagnosis of or checking what is clearly we are encountering. What is the issue in front of us? So troponin is the gold standard. Other tests come later or can be done in order to check other issues. ProBNP moves also work hand in hand, although not in a similar way with HSCRP. Those two are used for prognosis. Thank you. Back to you, moderator.
Thank you, Agri. Yeah, I think we don't have any other question coming in. So allow me to bring you back so that you can give us your parting shot so that we can adjourn our presentation today. Back to you, Agri.
Thank you. I really appreciate your audience. And as we know that the cardiovascular events are a very great medical importance, especially in today's world where lifestyle has drastically changed. And we should consider these biomarkers with the greatest interest so that we can save lives. And also key elements in reporting. It's not good for us only to report the values, the levels, and also the reference ranges. Let's give details that will help clinicians to do a diagnosis, to make quick decisions on certain issues. So my parting shot will come this way. According to the Comprehensive Global Burden of Disease Project, the leading risk factors for ill health and premature death are linked to lifestyle. What we drink and how much we exercise, disease prevention does not occur in hospitals. We need the whole society to be involved. That's from Jonas Gar Stowe. So even as we consider helping patients to get better by participating in diagnosis and monitoring of disease, we should also consider our health. Prevention is better than cure. Thank you. Back to you.
Yeah, thank you, Agri. Just as you were doing the parting shot, another question came in, and I'm requesting that you answer it before we adjourn. And the question is from one of the participants, and it goes, can you do troponin when checking the PT progression?
Troponin and checking PT.
Yeah, PT
Prothrombin
progression. Yes.
Yes, troponins are key in checking for MI. And also, before this patient comes for, before this patient is spotted in the hospital setting, and we have a presumption that this patient has MI. Thrombin time is another test that's very important in thrombotic risk testing. It's one of the key biomarkers in thrombotic risk testing, whereby you see in formation of microthrombi, especially along the blood vessels, is one of the key elements that can contribute to heart attacks or heart failure or MI. So it's one of the issues that we should consider in emergency situations. That's troponin being among them. But with the prothrombin time, apart from cardiovascular events, there are other issues that come in with prothrombin time, especially when we are checking issues pertaining to hemostasis and coagulation. It's another line of testing that that in hematology that can be related to cardiovascular events. So there is a time that it can come in for diagnosis of whether here we are dealing with acute MI here, or there are other issues that are involved in it. That's where we can go even to scans to check, CT scans to check whether there are thrombotic events like DVT or even arterial thrombosis, which can play a key role, especially in cardiac events. Yes, we can do. Also, it means that according to my explanation, we can do troponin alongside prothrombin time. Thank you for that question.
Thank you, Agri. Allow me to end this session today, but we will continue giving you, the medical lab practitioners, good presentations as we move forward. We hope that we'll be able to do another webinar, probably tomorrow. We'll be doing a schedule in the course of this evening. But we urge you that you still reach out to us in case of any challenges that you're facing. And then on behalf of Lab Medicine Society of Kenya, we wish you the very best of luck as we get into 2026. And we welcome you back to Lab Medicine Society of Kenya so that we continue working together. Otherwise, my name is Arthur Imari, and I wish you a good evening. Thank you.
Thank you, Arthur, and all the rest. Thank you. Have a happy new year tomorrow. Thank you.
Yes, see you.